So I have been told to speak on management of PIK3 inhibitor alpelisib induced hyperglycemia. Now, frankly, I have not handled even one case clinically, so I'm not an expert to speak on this. But nevertheless, the information in public domain is what I've tried to correlate with my practical understanding of diabetes management. So alpelisib mechanism is mainly through PIK3 inhibitory activity and especially against the PIK3 alpha subunit. And in advanced breast cancer, it is helpful with patients with the mutation of this alpha subunit. So this is what my understanding of the molecule is as far as the oncologic aspect is considered. Now, where does it relate to insulin is the question. So we know that insulin works through these pathways, and there are three important molecules when insulin is helping in glucose uptake into cells. So this mechanism operates in every cell of the body, and especially so the pathway involved in insulin action is the PIK3 pathway, the PDK1 pathway, and the PIP3 pathway. So if you see this diagram, this is the insulin molecule, which is in the circulation, which attaches to the insulin receptor, which then through various proteins is known to act through the PIK3 kinase and then move on to help in glucose uptake through the GLUT4. So this is how glucose uptake in the cell operates. Now, if you have a molecule which is going to inhibit this pathway here, PIK3, you're going to have inhibition of this glucose uptake. So, and that is what causes hyperglycemia in patients with alpelisib usage. So you can see this is what happens, that the insulin receptor pathway is blocked over here at this PI3 kinase, and then the glucose remains in the circulation and fails to enter into the cell because this is interrupted. Now, as a result of this, there is a decreased glucose uptake, mainly in the skeletal muscle, in the adipose tissue. In the liver, there is excessive glycogenolysis and glycogen synthesis is reduced, and pancreatic insulin release is stimulated. So there is an element of hyperinsulinemia. So it's a state of insulin resistance where you have high insulin in the body, high glucose in the body, and that is producing hyperglycemia. So that is why we say that this drug is known to cause insulin resistance. So insulin resistance is the mechanism by which hyperglycemia occurs with alpelisib usage. Now, is it a magnitude of problem? Do we need to worry? I think probably yes. So that is why I'm here. So there have been reported severe hyperglycemic symptoms, especially HHNK and DKA have been reported with use of this drug, and even some fatal cases are being reported in the post-marketing surveillance. However, we need to understand that with use of this drug, there is a specific indication, very few population would really get it, but we need to be aware of this very common happening of hyperglycemia seen in nearly 65% of patients in the SOLAR trial. And nearly the grade 3 hyperglycemia, that is sugars of 250 to 500 in the fasting state, was seen in nearly 33%. So 1/3 of the patients getting the drug would manifest with some of the hyperglycemic manifestations, and grade 4 was seen in as much as 4%, ketoacidosis in about 0.7%. So definitely it's a worrisome complication and it definitely needs to be dealt with. Also, we need to understand that hyperglycemia forms nearly the most frequent adverse drug reaction which has been reported, which has led to discontinuation in the studies. And it has also been an important cause for dose reduction of the drug. And it has been the commonest lab abnormality which has been seen as a ADR in various trials with alpelisib. So hyperglycemia should be the first thing that comes to the back of the mind when we are thinking of starting this drug or when we are using this drug and monitoring our patients. So how would you go ahead with the treatment then? So once you have diagnosed the degree of hyperglycemia, the fasting plasma glucose is the standpoint. So fasting plasma more than 126 is what we call as diabetes. So between 126 and 160 fasting plasma, there is no need for adjustment required. We can initiate or intensify anti-hyperglycemic agents. I'll come to that. And we can still continue the drug. And here, if the fasting rises above 160 to 250, there is again no dose adjustment with the alpelisib required. But again, intensification of anti-diabetic medications are required. If fasting does not decrease below 160 within 21 days, under the appropriate anti-hyperglycemic treatment, then there needs to be a 1 dose reduction of alpelisib. And then you follow the fasting glucose value according to the specific recommendation. Now, if there is grade 3 hyperglycemia, that is fasting is already between 250 to 500. Ideally, such a patient should not be started on the drug, but if the patient is having this value on the drug, then you interrupt the drug, then initiate or intensify the oral hyperglycemic treatment and consider addition of these medications for at least 1 to 2 days until it improves or as much as it is clinically indicated. Sometimes you may need to give insulin for 1 or 2 days to get the hyperglycemia under control. If you have a physician and a diabetologist at disposal, it would be preferable to give insulin to get the sugars controlled as early as possible. Administration of IV hydration is required to prevent the occurrence of electrolyte imbalance and ketoacidosis. And if the fasting reduces to 160 within 3 to 5 days, then you can resume the alpelisib at one lower dose level. But if it does not reduce below 160 within 3 to 5 days, it is better that the physician is consulted for diabetes and the drug is interrupted permanently if it does not reduce within 21 days of therapy. So it has to be given very supervised if the fasting plasma glucose remains after above 160 in spite of aggressive diabetic management. If there is grade 4 hyperglycemia, that is more than 500 milligram per deciliter, definitely there is a need for interruption and intensification of drugs for diabetes treatment along with insulin, along with fluids. And within 24 hours, there should be a reduction. And as soon as the fasting plasma glucose goes below 500, the recommendations for grade 3 should be followed. And if the fasting plasma remains high or the patient lands up with complications, then the drug needs to be discontinued permanently. So what are the medications preferred? I showed you the mechanism of action, and in the SOLAR-1 trial, which has been the major trial, which has guided therapy, the guidance has been mainly as metformin for first line use. Because why metformin? Again, I'll come to that. Initiate with 500 milligram once a day. Based on tolerability, go to 500 twice a day, followed by 500 at breakfast and 1000 at dinner, followed by increase to 2000 in the daytime in 2 divided doses. So 500 to 2000 is the dose of metformin which can be used. And then second line is SGLT2 inhibitors and followed by insulin sensitizers, that is the TZDs and the DPP4 inhibitors. Now, what are these drugs? It's a big array of drugs. So this is what we call as metformin, that's a biguanide. DPP4 inhibitors are all your gliptins. Then SGLT2 inhibitors are all your gliflozins. So canagliflozin, BAPA, and empagliflozin. Thiazolidine are glitazones, that is pioglitazone and rosiglitazone. Now, the caution here is that we know that alpelisib itself has a lot of side effects, but our drugs which we are talking about for diabetes do have a lot of side effects. So metformin mainly has GI side effects. The SGLT2 mainly has genitourinary side effects. And the DPP4s are relatively safe in that aspect in terms of side effect profile. And TZDs are contraindicated in heart failure and in fluid retention. So if you have to understand this, in alpelisib, there are a lot of GI side effects. There is a chance of urinary tract infection and there is a chance of having ECG changes. So if in case you have coexistent side effects of alpelisib, it is better to avoid oral drugs and think of using insulin in such patients because you might worsen these side effects in the bargain. What are the peculiarities of these hyperglycemia? The peculiarity is that the first occurrence is seen within 15 days. It's on an average from 5 to 500 days. So it can occur at any moment of time. This was a study in which they showed that in 187 patients, 87% of these could be managed with oral anti-diabetic agents, and 76 required more than one drug beyond metformin. So grade 2 hyperglycemia, the median time of improvement was around 8 days. So it required at least 8 days for control of glucose. And those patients who were withdrawn the drug and were continued on fulvestrant, they usually return to normal. So the diabetes is reversible. So this is an important aspect that we need to know in terms of hyperglycemia. So insulin is recommended in all morbid patients and complicated patients, especially where LFTs are deranged and GI side effects are there. The good news is that given the short half-life of alpelisib, We expect glucose levels to normalize immediately after interruption. Bad news is that all above drugs can worsen GI side effects, GU side effects, liver dysfunction, ketoacidosis or fatigue, and reduce appetite. So if you have a patient who's not eating well or is losing weight, there's a high chance that weight loss will worsen in these patients. So why metformin as first line? As I said, that metformin, one of the pathways is the PIK3 pathways, but there are many other pathways to which metformin can help glucose uptake. So this is how metformin helps in improving the glucose transport across all these organs, even if the PIK3 pathway is blocked. So it is important to understand that metformin is more rational in terms of usage, but in terms of side effect profile, you'll have to clinically have a judgment. So pre-screening is very important for using this drug. So pre-screening with fasting plasma glucose and HbA1c is necessary. At least a random plasma glucose needs to be done. Monitoring of fasting needs to be done at least once a week for first 2 weeks, then at least once every 4 weeks, and then once every 8 weeks. Ideally, you should be monitoring at every follow-up visit. HbA1c monitoring every 3 months. Ideally, a physician should be into picture so that especially if the patient has high risk factors like obesity, then family history of diabetes, or there is concomitant use of systemic steroids, or the patient's age is more than 75, the chances of having this complication is very high. Lifestyle counseling also is an important part of this treatment. Now, patient counseling is very important because most of the diabetes remains undiagnosed if the patient doesn't suspect. So patient needs to be explained about this complication. Patient needs to be told that the patient needs to report if any of these symptoms of diabetes. We all know about it, but these need to be given as a handout or a pamphlet to the patient. In non-diabetic patient, what is the status? In uncontrolled patients, it has not been tried and tested. So preferably avoid using it in uncontrolled type 1 or type 2 patients. In controlled patients, it can be used, especially if the medical history is permitting the usage of this molecule, considering the side effect profile. And there needs to be an intensification of therapy. So anticipated increase in the dosing and closely monitoring this patient is required. And it may require interruption, reduction, or discontinuation, especially if there is signs of impending diabetic ketoacidosis or hyperglycemia. So this patient needs to be on a daily monitoring schedule at home. So this is all I have to present in this, and I hope that we would get more experience as we start using the drug in clinical practice. Thank you so much for the patient listening.